Hi, you're watching Nursinga, and today we're going to talk about fluid, electrolytes, and acid-base balance. So let's start with some of our definitions. Fluid is the water with dissolved or suspended substances. Typically these are things like glucose, proteins, ions, and cells. An electrolyte is a mineral salt that dissolves in the water and separates into ions. So what's an ion? Then it's a charged particle, and there are cations that are positively charged particles like sodium, potassium, calcium, and magnesium, and there are anions, which are negatively charged particles like chloride, bicarbonate, and phosphate. Fluids are distributed throughout the body with about 65% of the fluid in the intracellular space, so inside your cells, and about 35% in the extracellular space or outside of your cells. 25% then of this extracellular fluid is interstitial or between the cells. And so basically think about it as almost like kind of no man's land or a barrier between the intravascular and the intracellular fluid. And then 8% then is in your blood vessels, so that's intravascular, and about 2% is transcellular, which is in small fluid pockets like your CSF and the linings of your joints and in between the visceral and parietal layers of like your pleura. So homeostasis is an important concept when we're talking about fluid, electrolyte, and acid base, because all of these things are constantly moving and shifting in order to maintain balance. Ions move through either passive or active transport. Passive transport is referred to as diffusion, where it moves from a high to a low concentration. The ion channels are open, allowing the ions or these salts to just kind of move by kind of happenstance. They're kind of bouncing off of each other, and then they're hitting these channels and just kind of passing through the opening from one cell to another. Active transport, though, occurs when we selectively move something from one area to another, and we tend to move low to high to create a pressure gradient, such as the sodium-potassium pump. And active transport requires ATP or energy in order to work. So active transport, you see I made AT and P in active transport green, but just to remind you that it requires ATP or energy in order to work. Water then moves either very passively by osmosis from a low pressure to a higher pressure to try to balance those out. So it moves from like a lower concentration to a higher concentration to balance out the higher concentration and dilute it. This occurs when ion channels are closed and the salts can't move, so then the water moves instead to equalize the concentration. Filtration occurs not really as an active process, but more as a pressure process from, again, high to low pressure using hydrostatic pushing and oncotic or colloid pulling pressure at the level of the capillary beds to exchange fluid and gases between the intravascular and the interstitial and cellular spaces, and then also at the kidney in order to make urine and to get rid of salts and urea and wastes and potassium, as well as fluid. Edema is the result of an error in filtration. So just think about that for a second, because water should go in and the water should come back. And so then there's a breakdown somewhere in there between the pushing and the pulling and the fluid going in and out. And so typically edema is a problem with colloidal or oncotic pulling pressure, and there's not enough protein to pull it back in, or there's some sort of obstruction that's not allowing it to get pulled back into either the lymphatic system or the venous system. Fluid intake and absorption is impacted by oral intake, so your fluid, your food, G-tube, and thirst is triggered by hypovolemia. So if there's an increase in blood osmolality, that will also trigger thirst, or a decreased blood volume. But either dehydration or hypovolemia or hypotension will trigger the receptors in your blood vessels to say, hey, you need to drink some more. Fluid distribution is mediated by filtration and osmosis. So the movement between spaces like the kidneys or the capillaries, and osmosis, or the movement between cells. And fluid output is regulated by, or kind of measured by, sensible and insensible losses. So sensible losses are things we could measure, right? The kidneys make urine. If there's diarrhea, we can measure it. If you vomit, we can measure it. But then there are insensible losses, like we can't measure how much you lose through inhalation, exhalation. We can't measure how much you lose through sweat. Fluid volume balance is a critical concept. So clients at risk for fluid volume imbalances include people of extreme age, so they're very young and very old, people with significant medical history, people in very hot environments or cold environments, or really dry environments, poor diet, poor nutrition, and then certain medications as well. Fluid volume overload is more fluid in the vasculature than the person can handle, and this will lead to weight gain, hypertension, tachycardia, bounding pulses, crackles, dyspnea or orthopnea, pitting edema, and jugular vein distension. Fluid volume deficit then is too little fluid in the intravascular space, and this leads to weight loss, hypotension, especially orthostatic hypotension, tachycardia, tachypnea, poor or tenting skin turgor, dry, cracked mucous membranes, and oliguria, which is that scant, dark urine. On labs, we know that the H&H changes with fluid volume or fluid balance. So with fluid volume overload, we experience a hemodilution, or a decrease in our H&H due to an increase in plasma volume. And with fluid volume deficit, we experience hemoconcentration, or an increase in our H&H due to a decrease in plasma volume. Fluid balance in children is similar, but just there's some slight differences that need to be pointed out. So probably fluid volume deficit is the primary concern in kids, and this is when output exceeds intake. So diarrhea, sweating, medications, DKA, vomiting, infections, fever, diuretics, trauma, just being NPO, especially in a small child for a short period of time, can cause them to become fluid volume deficit, and then burns or anything that causes third spacing. The signs and symptoms in kids are only slightly different, but sunken eyes, sunken fontanelles, lethargy, weakness, a really dry, cracked, furrowed tongue, tenting, again, poor skin turgor, such a great picture, tachycardia, hypotension, oliguria. Kids that get fluid volume deficit, they're such little limp noodles. The treatment is to maintain fluid and electrolyte balance and to replace any fluid volume deficits. Kids typically get 20 milliliters per kilogram fluid boluses. Use infusion pumps for accurate INO rather than trying to eyeball it. And we don't give potassium replacement until the urine output is adequate, because the kidneys are responsible for safe potassium levels or balance, and if the kidney perfusion is not adequate to clear potassium, if it gets too high, then that can cause lethal arrhythmias and death. The key really is treating the underlying cause, so figure out what's causing the fluid imbalance and go after that. Fluid balance in the elderly. Elderly are at greatest risk for fluid volume deficit because they have a lower body percentage of water. They have decreased thirst mechanism, and they may have difficulty obtaining fluids if they have impaired mobility, or they may avoid drinking adequate fluids if they have an issue with elimination. And they also may be taking medications that increase fluid excretion. They're more likely to experience acute and chronic illnesses, and again, access to fluids for whatever reason can become a problem. Instruct caregivers of older adults with cognitive or mobility deficits to offer fluids on a schedule. Great infographic about the RAS system, something, that I think nurses and medical providers in general should be comfortable with and familiar with in terms of ADH, which is the antidiuretic hormone that tells the kidneys to, retain water to increase blood volume. And then the activation of the RAS system triggers, so angiotensin is converted to angiotensin 1, that's then converted to angiotensin 2, and that then has some sympathetic effects as well as triggers the release of ADH and aldosterone. Aldosterone tells the kidneys to hold on to sodium and water and loses potassium. So we have ADH that's saying reabsorb more water into the blood, and aldosterone that is saying reabsorb more sodium and water into the blood. And these two in conjunction with angiotensin that causes arterial constriction to improve your blood pressure, all are great in terms of saving your life if you are hemorrhaging, but they're really bad when it kicks in as part of stress. So if you are somebody who has elevated blood pressure due to constant stress and activation of the RAS system, this is bad because it's really hard on your body. So ACE inhibitors work by preventing the conversion of angiotensin 1 to angiotensin 2, effectively then kind of blocking that entire cascade of activation of the angiotensin 2 sympathetic stuff, the activation of the ADH, and the activation of the aldosterone all at the same time. As a safeguard, we have ANP, which is kind of like a antagonistic hormone. So if the heart is getting fluid volume overload, it says, hey, kidneys, you got to get rid of some of this fluid. So it increases the GFR and it decreases reabsorption of sodium, and it inhibits the release of renin, aldosterone, and ADH. So ANP actually kind of turns off the RAS system. It's kind of like a safety mechanism so we don't stroke every single time the RAS system kicks in. Another great picture just talking about the difference between isotonic, hypotonic, and hypertonic solutions and what happens to cells that are in those different solutions. So with an isotonic solution, it has the same concentration of molecules or ions inside and outside of the cell, so there's no ion shift, there's no fluid shift. With a hypotonic solution, if the ions can't get out, then the water is going to have to go in to try to balance the concentration, and it's going to cause swelling, and it actually could cause lysis, right? The cell could actually get so large that it actually ruptures or pops. And then with a hypertonic solution, there's more ions on the outside than on the inside, and so if the ions can't move, then the water is going to move, and the water is going to come out of the cell, and the cells are going to shrink or shrivel up, and this is called crenation. And then the cure for that obviously is rehydration, versus the cure for somebody, cells that have been lysed. There is no cure. Once they rupture, they're ruptured, and we can't do anything about that. All right, so our nursing interventions for patients with fluid imbalances are safety, skin, medications, diuretics if they have fluid volume overload, fluids if they have fluid volume deficit, careful INO and daily weights because that's the best indicator of fluid status, and safety. So moving on to electrolytes, it's important, I think, to understand, sodium is the primary extracellular cation. So that means that it's not inside the cells, it's out in the serum. So it's in that plasma, and it's going to be a much higher level than something like potassium, which is the primary intracellular cation. And so while you may have the same amount of sodium and potassium in your body, potassium's in the cell. So it's like inside those blood cells, it's inside your body cells. And so when you do a serum potassium level, you're not going to see the potassium because it's hidden away, it's sequestered away in those cells. Okay. Chloride is the primary extracellular anion, right? So sodium and chloride, or sodium chloride, is normal saline, and that's why it makes sense that when we talk about an isotonic IV fluid resuscitation, or when we're talking about just maintenance fluid, that the majority of fluids that we use are sodium chloride, because those are the two primary ions that are found in your blood vessels. Calcium and phosphate have an inverse relationship with each other, whereas as phosphate rises, calcium decreases, and as calcium rises, phosphate decreases. And then we have magnesium, that's really important, and bicarbonate. So let's take a look at some of these individually. Sodium. So if you can remember S for sodium, remember seizures and safety. The person who has a sodium imbalance is at risk for seizures. Hyponatremia is the word for low sodium in the bloodstream, and that's a sodium less than 135. Typically when they get in the range of about 120 or lower is when you're going to start really seeing seizures. We see this with increased water or loss of salt, and the osmolality decreases. The person will experience lethargy, headache, confusion, altered mental status, seizures, and obviously a problem with safety. Patients who have hypernatremia have decreased water or excess sodium, and the osmolality is increasing, and they experience fever, restlessness, hypertension, edema, dry mouth, altered mental status, and again, seizures, and safety is a primary concern. Patients experiencing dehydration from activity, such as sweat, should be encouraged to increase water and sodium intake, like oral rehydration solutions or Gatorade, because they lost both salt and water with sweating. Teach patients with sodium restrictions how to avoid hidden sodium in processed foods. So we oftentimes restrict salts for patients who have fluid volume overload to decrease fluid retention. Potassium, normal range for potassium is 3.5 to 5. And patients who have hypokalemia typically get that from diarrhea, vomiting, GI suctioning, alkalosis, potassium wasting diuretics, or excess insulin. They'll experience muscle weakness, constipation, cardiac dysrhythmias, and need to be on the cardiac monitor. Hyperkalemia is from things like increased oral or IV potassium, cellular damage, lack of insulin, kidney failure, potassium-sparing diuretics. And they will also have muscle weakness, but then they have diarrhea, cardiac dysrhythmias, and should be on the cardiac monitor. When caring for a patient with high or low potassium, provide education on dietary choices. Many people really are not aware of the potassium content in foods. Safe potassium replacement is really critical. We like to do oral potassium as the preferred route when possible, especially if they're just outside of the normal range, if they're hypokalemic, because that's safer than IV potassium. The maximum dilution is at 1 milliequivalent in 10 milliliters, and typically it's run at 5 to 10 milliequivalents per hour. If it's faster than 10, they need to be on a cardiac monitor, and most places will not administer potassium faster than 20 milliequivalents per hour. There are some ICUs that will go up to 40. Calcium, the normal range is 8.4 to 10.5. Hypocalcemia occurs in patients with nutritional deficiencies, vitamin D deficiencies, kidney failure, chronic diarrhea, alkalosis, laxative use, hypoparathyroidism, and blood transfusions. When you have hypocalcemia, you experience numbness, tingling, hyperreflexiveness, muscle twitching, Chvostek and Trousseau sign, and tetany. Hypercalcemia occurs with prolonged immobilization, hyperparathyroidism, bone tumors, thiazide diuretics, and patients experience anorexia, nausea, vomiting, constipation, loss of reflexes, lethargy, and even cardiac arrest. We can get hypocalcemia from a thyroidectomy because the parathyroids are removed. So this is actually hypoparathyroid. It's important to have both calcium and a trach kit ready and at the bedside following a thyroidectomy. As I said, phosphate has an inverse relationship with calcium. So hypophosphatemia is often caused by malnutrition or hypercalcemia, as well as hyperparathyroidism and excessive antacid use. Patients with hypophosphatemia have signs and symptoms similar to hypercalcemia, lethargy, weakness, anorexia, and nausea. Patients with hyperphosphatemia have hypocalcemia, kidney failure, hypoparathyroidism, DKA, rhabdomyolysis, and they're typically asymptomatic, but they develop the signs and symptoms of hypocalcemia as that occurs. So you may see the Chvostek and Trousseau sign and the hyperreflexivity, as well as the numbness and the tingling. Magnesium, normal range is 1.5 to 2.5. Hypomagnesemia occurs from malnutrition, chronic alcoholism, chronic diarrhea, laxative use, and thiazide diuretics. You may see Chvostek and Trousseau sign with hypomagnesemia, as well as the hyperphosphatemia and the hypocalcemia. Hyperactive reflexes, muscle cramping, and seizures are possible with hypomagnesemia. And so the differential between those three is really going to be history. Hypermagnesemia then is usually directly related to excessive use of magnesium laxatives or antacids or end-stage renal disease. And you need dialysis as a treatment for end-stage renal disease because there's no other way to clear the magnesium. Lethargy, loss of reflexes, respiratory depression, even respiratory arrest, dysrhythmias, and cardiac arrest can occur with hypermagnesemia. And if you're giving somebody a magnesium drip, you need to monitor deep tendon reflexes as well as respiratory status very carefully. So moving on to acid-base balance, I think it's really important that you understand kind of all of the parts of reading a blood gas, but we're going to start really simple. So let's talk about pH for just a second. pH is the potential for hydrogen, or the potential to accept more hydrogen. The higher the pH, the more acid the fluid could accept. So if you have a high pH, you're actually very alkalotic. You have alkalosis, or very base. The lower the pH, the less acid the fluid could accept. So low pH means that they already have acidosis. There are two main types of acids in your body. There's carbonic acid, which is excess CO2, and that tends to be expelled with ventilation. And then there are metabolic acids, lactic acid and citric acids, that are created as byproducts of metabolism and expelled through the kidneys through hydrogen excretion. The respiratory and urinary symptoms interact with the bicarbonate buffer system to preserve a normal pH level. The blood buffers act immediately to bind to hydrogen, and these are things like bicarbonate, hemoglobin, proteins, and phosphate. Hydrogen can be sequestered in the cells like red blood cells, and then potassium leaks out. So it's not uncommon with acidosis to have an elevated potassium as kind of a secondary mechanism of the blood buffering. Then the body increases your respiratory rate because I'm going to exhale CO2 to compensate for my increase in either carbonic or lactic acid. This is a quick process, but it cannot be maintained for a long period of time because you're going to get tired. And then the kidneys will secrete more bicarbonate and excrete more hydrogen. And this is slow, but it can last a lot longer. And the bicarbonate then is obviously one of those blood buffers that's going to go into the bloodstream and be able to neutralize hydrogen and then allow the kidneys to excrete the hydrogen and the waste. So normal ABGs, pH should be between 7.35 and 7.45. O2 should be 80 to 100. CO2 should be 35 to 45. And bicarb should be like 22 to 28. And different books have different ranges. So you might see 21 to 27, 22 to 26, or 22 to... Okay, so let's look at a blood gas. The first thing we want to look at is the pH, and we want to determine, is it normal, is it high, or is it low? If it's low, the patient has acidosis, and if it's high, the patient has alkalosis. Then we want to try to figure out why. So the next thing we're going to do is look at the bicarb and the CO2. So looking at the CO2, which should be 35 to 45, if the CO2 is normal, then it's not a respiratory issue, probably. And then we're going to look at if it's high or low. The interesting thing is that the respiratory acids move opposite of the pH. So CO2 is an acid, it's carbonic acid, right? So as that number climbs higher, your pH is going to go lower. So those have an inverse relationship with each other. So respiratory is opposite. And a respiratory acidosis then has a low pH and a high CO2. A respiratory alkalosis has a high pH and a low CO2. And the bicarb for a respiratory problem would be normal. Respiratory acidosis is caused by things like hypoventilation, head injuries, opiate overdoses, choking, lung disease, chronic COPD, and the later stages of pneumonia. Respiratory alkalosis is caused by things like hyperventilation, pain, emotional trauma, but also the early stages of asthma and pneumonia when the patient is hyperventilating before they become severely hypoxic. If the CO2 is normal and we look at the bicarb, bicarb is an alkaline. So when there's less bicarb, there's more acid, and so bicarb moves in the same direction as the pH. So if respiratory is opposite and metabolic is equal, you can remember the mnemonic ROME, R-O-M-E, respiratory opposite, metabolic equal. So if the pH is low and the bicarb is low, then we have metabolic acidosis. And if the pH is high and the bicarb is high, then we have metabolic alkalosis. And metabolic acidosis is seen in things that cause hypoperfusion to the cells that results in a shift into essentially anaerobic metabolism. And these include things like diabetic ketoacidosis, shock, sepsis, kidney failure, prolonged diarrhea, things like that. Metabolic alkalosis then is caused by loss of acids or overdose of an alkaline like sodium bicarbonate overdose, prolonged vomiting, or NG tube suction. So using that mnemonic again, respiratory opposite, metabolic equal, this is just a very simplified visual of what how the arrows move or line up when you're interpreting your blood gases. So if you want to practice, it's important, I think, also to always consider kind of the situation. So the first one is a 19-year-old male brought into the ED with a femur fracture. So we could anticipate that he's in a lot of pain. Vital signs, his temp is 98.7, his heart rate is 110, his respiratory rate is 24, and his blood pressure is 117/63 with a saturation of 97% on room air. He is very anxious and complains of tingling around his mouth and his fingers. His pH is 7.48, his CO2 is 32, and his bicarb is 24. So what we know of our arrows is that his pH is elevated, and that makes him alkaline, and his CO2 is low, and that makes it a respiratory problem because the arrows are moving in an opposite direction, and his bicarb is normal. So he would have a respiratory alkalosis from hyperventilation and pain. The next is a 40-year-old woman with diabetes who's been admitted for a skin wound. Her temp is 101.9, her heart rate is 124, her respiratory rate is 22, and her blood pressure is 140/86. She's 94% on room air. She's complaining of severe thirst and frequent urination. Her blood gas has a pH of 7.28, which is low, right? So she's acidotic. She has a CO2 of 30. Now that's low, but it's not a respiratory problem because it's not moving in the opposite direction. And then she has a bicarb of 18, which is also low. So she has 3 down arrows. So this is a metabolic problem, right? It's an acidosis, and it's a metabolic acidosis. So why do we have a 3rd arrow? We see this when it's compensated. So she is blowing off CO2 to compensate for the metabolic acidosis. So in this case, this is a compensated, and it's not well compensated, but she's trying, compensated metabolic acidosis. All right, well, I hope that helps. It's always helpful to review these, keep practicing, and you know, things like flashcards are helpful, I think, a lot of times with lab values and with acid-based stuff. As always, thank you for watching, and I hope you have a great night.